tube out, and then we put them on supplemental oxygen, and then we watch those ABGs closely to make sure they're not going back into respiratory distress, okay? Complications, again, based on delivery and amount. And then, of course, fire. We have to make sure that patients who are at home are aware, no open flames, no cooking, no candles, etc. Toxicity. What ends up happening is pay attention to the signs and symptoms of toxicity. They have the chest discomfort, restlessness, difficulty breathing, all listed under there. And respiratory difficulty is definitely a key, because you say to yourself, they're on oxygen, why are they having difficulty breathing? Because it should be helping them. It doesn't make sense when it goes the other direction. Incentive spirometer, we've already mentioned. Again, every hour while awake. Of course, while turning that patient. Now, patients that are in ICU, there's a button on the bed that you can put for vibration or percussion, depending on the bed. Manufacturer, say either or. And that would also do the same thing, is it's breaking, just like those CPTs are, breaking up those secretions and getting them to loosen those secretions to prevent and treat. So you have incentive spirometer, you have the percussion of the bed, you have CPT, nebulizer therapy, how often the patient needs that bronchodilator. Maybe it needs it with an anticholinergic. And so we know albuterol is our bronchodilator. We watch for tachycardia. The ones we're careful with is the level of albuterol, right? Then we give it to those cardiac patients. Remember the difference? Level of albuterol does not cause tachycardia. Albuterol causes tachycardia. And then it's with an anticholinergic. What do we remember about anticholinergics?
Dry you out.
Where?
They dry you out.
They dry you out. So what does that mean? Constipation's one. 3 things about drying out. Constipation. Dry cough. Sure, we'll go with dry cough. Dry mouth kind of goes along with that. And one more thing. Urinary retention. Yep. So constipation, urinary retention, dry mouth, dry cough from the anticholinergics. They use it in combination, right, with either another bronchodilator of albuterol or a level of albuterol. Keep in mind, level of albuterol, again, does not cause a tachycardia. So those patients who have heart conditions would have Xopenex or level of albuterol, same drug. So with that said, CPT again, with a percussion of bed. Here's just a picture of cupping. One thing you want to make sure is the patient is either one sitting upright. You don't necessarily have them leaning on their bedside table because that bedside table can move. But you can do a side lying position, always starting at the base of their lungs and then working up, okay? Not only does the beds in ICU do that with percussion and the vibration, there's also a vest that can be put on. The problem with the vest is they don't come in very extra large, okay? They're for smaller types of patients. So if you can get a bed that does it, or your hands, or there's also a plastic doohickey. It looks like a suction cup, because that's what it's doing, is when they're beating on you, they're actually suction cupping. But it's a, I don't know what color, skin tone color of a suction cup that has a little handle here and a cup here. And that also can be used if you don't want to just use your hands making a C cup. Same kind of concept with that.
Can we put the vest on them? Or is that something that we...
You can put the vest on them. Yeah, usually respiratory does it. Depending, of course, the facility, because they're the ones that really should measure to make sure it fits them appropriately. But if you need to do it, and you don't want to use your hands and all that, and the vest is there, go ahead and put it on. Won't hurt. So non-invasive positive pressure ventilation. This is a fancy way to say CPAP or BiPAP. And so what we need to know is the differences between the two. So when we're talking about continuous positive airway pressure, known as a CPAP, continuous means that it's a constant flow of pressurized air, to maintain an open airway. we use CPAPs when we don't want to be invasive and do intubation, right? So those patients who are in respiratory distress but they don't want to intubate because of, for whatever reason, and we can use that as an alternative, non-invasive, they will get that positive pressure, that pressurized air to maintain, and it's a constant flow. Also eliminate snoring. So patients that have sleep apnea, right? That would be the CPAP at home idea, and it's constant flow. For our BiPAP, of our bi-level positive airway pressure, this is for central sleep apnea, not obstructive. Obstructive would be your CPAP because it's obstructive, meaning they need that constant flow. But central sleep apnea, that actually turns worse than would go to that CPAP. But central sleep apnea is a pause in breathing due to the brain failing to activate the respiratory muscles. So it's a pause in breathing due to the brain failing to activate the respiratory muscles. Obstructive sleep apnea has that, plus the airway gets blocked. So if the airway is not blocked, then they won't need the CPAP, they can just go ahead and do BiPAP. What BiPAP does is it's pressure on inspiration and a decrease, so it's an increased pressure on inspiration, increased in, right, inhale, inspiration, increased, and decreased with exhale or expiration. The pressure is decreased. So inspiration, the pressure is increased. On expiration, the pressure is decreased. So increased and decreased, where our continuous is constant flow. So let's just say the patient progresses and they can't tolerate that pressure or those masks for the CPAP, and then we move into intubation. Truly, the rule of thumb is 7 days for endotracheal tubes. Then that could lead to vocal cord damage. So if you've known anybody who's ever gotten extubated and they start talking, they're very hoarse, right? Even after surgery for general anesthesia. They have a scratchy throat, their throat hurts, and that's because they've had a tube down it. So they're going to be hoarse voice, but vocal cord damage comes 7 days. So the rule of thumb is if the patient needs it more permanent, they're going to go to a tracheostomy, because that is a more permanent device than an endotracheal tube. The problem with the endotracheal tube, yes, it protects the airway and all this, but the patient's gag reflex is suppressed. So if there's any secretions around that tube, they can't cough it out because their gag reflex or their cough reflex is decreased. They can't do it. We have to get that out. Okay? So that's a problem with that, per se. But their airways should be protected, right? If it's properly inflated. And how many has touched endotracheal tube in this room? A couple of you guys? Okay, I'll pass one around so that we can just see. At the end of an endotracheal tube, it's a balloon. Everybody knows it as a balloon, but it's actually called a cuff. And the reason that cuff is important to know is because when it's inflated, this cuff will inflate, and that's what puts it in place. So for those of you who've already touched one or seen one, you can just pass it along. But for those of you who haven't, please just take a peek at it. So the cough reflex is decreased. So here's a picture of one, just as a side view, animated, so you get a visual. So again, 7 days vocal cord damage. We move into a tracheotomy. Remember, it's permanent. Now, endotracheal teams need a ventilator, right? Because they can't breathe on their own, unless they're at the end of their ventilation time period and they're on a T-piece with that oxygen supply, and then we extubate them from there, okay? So when we're talking a trach, couple things about that. We're going to talk more about mechanical ventilation coming up. But with the trachs, more permanent. Long-term complications are listed, so make sure you pay attention to that. And then one thing that happens is patients who cannot talk. Now, with this A, you see one cuff, right? And it has a hole. That hole comes later on after the trach is, they're comfortable with it, we can learn how to do everything. Then that hole will help them talk because it allows air to pass through that vocal cords in order to produce a voice. So once we lead to that, then they would get a hole in the Shiley. That is what this whole thing is called, is a Shiley. Trach is the whole thing. This small endotracheal tube is called a Shiley, okay? Then if it's whole, it's fenestrated. It's called fenestrated. And then that means that it allows for the patient to talk. If the patient, you see, has no Shiley, no hole in this Shiley, but it has two cuffs, that is because we're preventing tracheal damage. Two cuffs, less, bigger than one alone. And you can see that in size. Holds it in place, but it's not one big one pressing against that trachea. This one has two smaller ones. The object of the game is just to keep it in place, right? But here, it's a big one. So, patients with any of these endotracheal tubes or trachs, communication becomes the key. So, how are they going to communicate with you? One thing is if they have speak a different language than you do, how are we going to communicate with that, right? The other thing is they won't be able to tell you, but they can show you. So there could be a message or communication board, they call it, and they can point to what they need. You know, pain, blah, 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 blah. But again, knowing translation, and of course in their native language, based on what your native language is and what you understand. So we would have to get a communication board that has those languages on there in order to understand the patient. So truly communication is the key. Anxiety, knowledge deficit, all that plays a role. Effective airway clearance, again, they can't do it themselves. They're leaving it for us to take care of them, okay? No airway, no breathing, no circulation, no patient, right? Airway is the key. No airway, no patient. Because they won't breathe and there will be no circulation. So our job then is to make sure that they had effective airway clearance as a whole. Potential for infection is self-explanatory. So when the patient is on mechanical ventilators, when a patient, and it is first thing that you heard, oh, your patient is on a bed in room 2. The next thing you should think is, ooh, I need to make sure I know my ABGs. Because ventilation equals ABGs. That is how you're going to know exactly what that patient's doing, respiratory and metabolic, right? Because that's what ABGs measure. So I'm going to mention it now so I don't forget it later. Review your ABGs for this test, because they will show up again, okay? With that said, mechanical ventilators, negative pressure, old words used to call it an iron lung. These are the days, long time ago, when patients had polio. Some of these iron lungs are still used for patients with ALS. And it's a type of negative pressure ventilator. And then muscular dystrophy also is another one who still uses these negative pressure ventilators. Positive pressure ventilators are the ones that we know more commonly now. The most common that we will see, and that we'll talk more about, is the volume cycled. Those are the ones that we see in normal ICUs and that we see more commonly. For those patients or nurses or you guys who are going to work in more of the NICU and newborn and infant areas, you're going to see time-cycled ventilators. And the reason why it controls inspiration. And then pressure cycled is that respiratory rate, exhale as passively. But getting back to the volume cycled, positive pressure that we see most commonly. When you're the nurse getting a report about your patient, and we're in ICU right now, so put yourself in ICU, we're getting a report on patient 2, okay? the nurse tells you that they're on a ventilator, mechanical ventilator. And the next thing that you should hear is the settings based on that ventilator. So you should hear, it's an AC control. So assist control, AC, not air conditioning, assist control of either the number 10 or 12. That means that's how much the ventilator is working for that patient. Assist control of that respiration is either 10 or 12. Then, the next thing you're gonna hear is IMV. That is intermittent mechanical ventilation. Intermittent mechanical ventilation. That means that the breaths are set at a rate of tidal volume flow. So the breaths are set at a rate of tidal volume flow. So we have AC so far, IMV. Then we will have a PEEP, that positive end expiratory pressure. And that magic number is usually 5, is a common number. And the reason, it's just what it says. It's a positive end expiratory pressure. So 5 times out of that 10 or 12 breaths, they're gonna have that PEEP, give that positive push at the end of expiration. Just what it says with PEEP. You're also gonna need to know TV, tidal volume. That is how much air volume is going in with every one of those 10 or 12 with the PEEP, etc. So tidal volume, it's the air volume. And then FiO2. FiO2 is a fraction of oxygen, which is your oxygen level. How much oxygen is that patient getting through that ventilator? So some diagnoses that are associated with the problems that happen with mechanical ventilators. Keep in mind, these patients will have to be on some form of soft wrist restraints. They will be sedated. Every 8 hours, that patient is going to be checked for altered mental status. That means that sedation will be turned off. The patient should arouse, and you should be able to assess neurostatus with those patients. Then, we're putting the sedation back on, because once they realize what is happening, they're going to stress out more. So, if you don't have those soft wrist restraints on them, or so bigger patients might need more than just soft wrist restraints, because a lot of times what ends up happening is the first thing they're going to do is grab to get that endotracheal tube out, because they're not used to breathing through their straw. They're anxious, they can't breathe as it is, and they think it's because of that, but in turn it's because of their own lung disease. There will be an NG or OG. And we mentioned this a couple weeks ago. The reason they have an NG or an OG, they don't do both, they do either or. But the option could be for both, right? So the NG or OG is strictly for gastric decompression. Want to make sure that that air is not sitting in that belly to allow that diaphragm to work. So it's not working against the ventilator in that tidal volume. Weaning is going to be all based again on those ABGs that we mentioned. So 48 to 72 hours after a patient comes in respiratory distress, they don't really start worrying about weaning, depending of course on the patient's comorbidities, etc. They want to get them comfortable, get that back to hemostasis, right, with everything that goes into play with that. And then they might think about weaning after the fact. So of course, checking those ABGs. CO2 detectors to check for replacement. One thing I didn't mention about the endotracheal, but I will. We'll go back to that in 1 second. So with weaning, again, the criteria is going to be based on what the ABG did, what the patient's showing signs of, etc., etc. So it's a collaborative effect when it comes to weaning. Then they move to that T-piece, or they might move and be extubated and move to a non-rebreather. But the goal is not to have to re-intubate them, right? That is the goal. So, when talking about the endotracheal tube, if you notice on the side of an endotracheal tube there was numbers, did you see that based on centimeters? That is also something else when the nurse tells you that you're the oncoming nurse, that the patient is ventilated, they're going to tell you at what centimeter that endotracheal tube is at. So you can check to make sure that at the lip line, that endotracheal tube is where it needs to be. 1. And then of course changing the dressing and things like that with it. Depending on the facility, the respiratory therapists usually do that. But it's all going to be based on where the lip is. That way you have an eyeball to make sure if that patient was, when you check the neural status by turning off the sedation, the best thing is propofol for ventilation because it has a very short half-life. So as soon as you turn that sedation off, the patient will start arousing. Okay? If it's a bigger patient, you might have to bolus them to get them back sedated and then keep it at a rate. Okay? And it's only a 50 ml bottle, so it runs dry quick, especially the more you have to use. Also, could be breakthrough sedation, Versed, Ativan are some of the breakthrough ones, but again, based on the protocols at your facility. So, patients undergoing thoracic surgeries. One would be, of course, pre-op assessment. That would be checking the respiratory system. Also doing PFTs, pulmonary function test. That is those patients pre-CABG, pre-any thoracic surgery. Any thoracic surgery. Pre-op preparation. If they are thinking that we'll have to put this patient on a mechanical ventilator, communication, we said earlier. And then any kind of drainage devices. So, one thing about chest drainage devices is to remove air or fluid being blood. So, with that said, air, they have the Pulvax now, Pluralvax, I should say. They're little boxes that sit right on the chest. Little catheter comes in, letting the air out. Woo, easy peasy. For patients that are undergoing bigger problems like a hemothorax or the CABG that we talked about last week that need their drainage system in a chest tube. Here we go. Okay? One biggest thing about chest tubes is they have to have 20 centimeters of sterile water inside in that water seal. Water seals with a little bit of bubbles, I'm talking like a little bubble, is fine. If that thing is bubbling blah, 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 all the time, that shows you that there's an air leak somewhere, whether it's in the system or at the patient, okay? If it is a bigger problem where they had to use this instead of that cute little device that they put upper, air and chest tubes, when we have air that is in that pleural cavity, we would put the chest tube higher, right? Because air goes up. You're in a swimming pool, you blow your bubbles, the air goes up. Same thing here, kind of the same concept. And we know that everything sinks, right, to the bottom. So if it's fluid, we would go lower, okay? It's important when you have a patient with a chest tube that you're checking lateral lung sounds as well, okay? Just to see if you can hear that lung expanding back to where it is, okay? So you want to check to make sure that they have lung sounds, especially if it's a bigger patient too. You should be able to hear lung sounds throughout, especially if the drainage is decreasing in there, if it's used for that hemothorax, which hemo just means blood where the lungs should be, okay? A couple other things is with our drainage system device here, there will be black, I was thinking no red instead of red, black Sharpie markers everybody should have in their pocket when they're working and they have chest tubes. Because you're gonna sign off at the end of your shift how much drainage was there. Whether you're gonna mark it with name, date, and initial, right? Name, date, initial. No. Initial, date, and time. Oh my goodness. Initials, date, and time. Okay, got that? Perfect. You don't have to put your name on it. Initial, date, and time. Unless you want to. No, don't. You take up too much room. So initial, date, and time. So we know that we have this. This one's going to the patient. And that's going to potentially, possibly suction. So one, in a world that it is, we want to make sure that this drainage system is always lower to help get it there. I have it on the desk so you guys could see it. Also, when we have titling in the tubing, and titling is just like the ocean or lake coming up on the beach and going back out, going up on the beach, going back out, it's the same concept. It's called titling. In here, titling is a good thing because that means the fluid's going and coming back, but it's not coming back in. It's getting to the point of dropping off into the drainage system where we need it to go. If for some reason there's a clot here, per NCLEX, you never milk a chest tube. Okay? Per the world of NCLEX. Per the world of NCLEX, you will never clamp a chest tube. ... Okay? However, for those of you working in the critical areas, you very well will milk a chest tube, and you very well might have to potentially clamp a chest tube, depending on the facility that you work in. Okay? So for purposes of that reason, I'm going to tell you how to do clamp, you just clamp it. But with milking, after seeing the titling that has stopped because there's an obstruction, you don't want to leave that fluid, whether it's a chest tube for a cabbage or for that hemothorax in the patient, right? You want it to go out and be done with it and go on its merry way, okay? So two things that are happening with titling. One, you're going to find a friend, okay, your confidant that you work with. You're going to take a friend into the room. Do you guys know that ACE wrap with the sticky stuff on the side called Elastoplast? Okay? That is what is pressure dressing on this chest tube, along with sutures and Vaseline gauze to seal the site, okay? Because it acts as a lubricant so it doesn't air leak. Something happens and it moves around it very well. And you will see the bubbling in the water seal that you shouldn't. 1 or 2 little bubbles is fine, but I'm talking boom, 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 okay? So, your friend will be holding pressure to that site, wherever that site may be, okay? You will have gloves on with KY jelly. Makes it slide easier. If you put the gloves with the KY, you lube them all up, and what you're gonna do is literally milk the tubing, okay? And you're gonna, it's like a miracle. So when you're milking, you're traveling down, and the goal is not towards the patient, the goal is to the chamber, to get rid of it away from your patient, okay? Always, always, always bring a friend, because they're going to have to hold pressure so you don't dislodge that. The worst thing you have to do is call the doc and say, I was just milking and I pulled out the chest tube. So you always call a friend to hold, and it should have really 2 hands, one holding the dressing and one holding the tube, because they should be feeling and fighting against you. Give your patient something for pain though, because it's gonna hurt them. Or her, or him, or her. Okay?
I'm clamping.
Clamping, you just clamp. With a patient, yep, it's a alligator clamp. They'll be at the bedside in case you have to do that. That would be if there's you see a bunch of bubbles and your patient's in really, really, really bad respiratory distress. There's probably an air leak somewhere. Clamping. Now, when you notice the drainage is decreasing, the patient's breathing better, and you can hear better lung sounds, that might be time to notify the physician. Pardon me. Notify the physician that, hey, this is what I see, minimal titling, not that it's getting stuck, there's just not hardly any. Probably time to pull the chest tube. Okay? Okay. Questions about this? Have you ever seen a chest tube be put in? It is a big stylet, like a needle, like a knitting needle. And they intercostal space, literally. So the patient, painful, but of course it relieves the other problems going on with it. Oh, next thing and last thing that we're going to talk about is splinting. We haven't talked about splinting with our cardiac patients. Anybody who has any type of surgery should splint. So if you work at facilities that have the heart, that the volunteers make the hearts pillows, and then you tell the patient to put them on their chest, that's a form of splinting. You can do it for abdominal surgeries, you can do it for any surgery and splinting. The idea with splinting is to push against so the patient can cough, they can move, they can turn, they can get up. A lot of times, especially with these thoracic patients, because that's what we're talking about, with their mid-sternal incision, that's what you usually get for coughs, because it hurts. And it's hurting here too, as it's hurting everywhere, because they just had major surgery. If they apply pressure on with their pillow, or you can take a bath blanket too and wrap it up in a log-ish thing and put it against them, and they're, you could push on them, and you think, oh my God, I don't want to hurt them. You push on them, my words was push, and then you want them to cough better and deeper, because that's how they're going to work those alveoli. They're not going to get atelectasis, especially when they're doing a spirometer and maybe the peak flows and all of that kind of stuff. You want them to use those bases. Use those alveoli to have that gas exchange. So splinting, just some of the pictures with splinting. Splinting goes a long way. And again, it's not just for these patients. It's anybody with abdominal surgery. Anything that is affecting this torso should be splinted, whether it's a kidney surgery, abdominal surgery, whatever the case may be that they have an incision. Okay? Questions about any of that? Is that you just stretching? I figured. Okay. 50 questions. Review your ABGs. Do you need me to open a math review again? You guys are doing well with those? Nobody's really said a hi or a ho about it. So, okay. So I'll open, I think we're on 4, 5, 6. I don't know. I'll look. I'll open